Welcome everyone to uh, Smilow Shares. And we're going to talk about a breast cancer update tonight on four topics with faculty from the Yale School of Medicine and clinicians. We are also clinicians at the Smilow Cancer Hospital. We'll each introduce ourselves and our topics as we go, and we'll give everyone a couple more minutes to kind of join in the webinar before we start. Please don't hesitate to add any questions in the Q&A tab or in the chat. Maybe we can start. We'll just go around amongst the four speakers. Let's introduce ourselves. I'm Dr. Melanie Lynch. I'm a surgical oncologist, and I am a breast cancer surgeon, and I'm the director of breast surgery in Bridgeport. And I get to work with this wonderful clinical team that's here tonight. So,
Hi, I'm Dr. Kathleen Fenn. I'm a medical oncologist with a specialty or interest in breast and gynecologic cancers, and I see patients in Trumbull and Fairfield and work with this excellent group.
My name is Kevin Du. I'm one of the radiation oncologists here in the Park Avenue Medical Center. And I'll echo that it's an amazing group of physicians to work with, and also an amazing group of patients to take care of. I'm very pleased to be here with everyone today and speaking to you about radiation therapy.
Hi, everyone. My name is Kamal Addagatla, one of the plastic and reconstructive surgeons here at Yale, and my office is based at Park Avenue in Trumbull. My primary focus is breast reconstruction, anything and everything breast, and so I'm here to support the needs of the team, however that might be, and happy to discuss things with you and answer any questions today.
So our topics for tonight are all update topics. What's new and different in our areas of practice? And I'm not going to talk so much about breast surgery as I am going to talk about breast cancer screening and high risk management. So I'm going to start by sharing my screen. And can everyone see that okay? Okay. Let's see how I advance it. There we go. So tonight we're just going to review the new breast cancer screening guidelines. I know it's been in the news quite a bit. I'm going to just give you some background as to why the screening guidelines were changed recently and why that's important. We're also going to talk about breast cancer risk factors and management of patients who are at increased or women who are at increased risk for breast cancer. And then we'll talk about risk reduction for patients who are at increased risk, including both medical and surgical risk reduction. So as we kind of cover the cancer care continuum tonight, I'm really going to focus mostly on the screening and diagnosis phase of care. As we expand our expertise in risk assessment, we're developing new clinical programs to address the needs of women who are at increased risk for breast cancer. As you know, breast cancer is the most common cancer in women. It accounts for 30% of all cancers in women. And we're going to frame our talk tonight with the stories of four women who have influenced our thinking about breast cancer. The first is Nancy Reagan, and the second is Dr. Bernadine Healy. So breast cancer incidence has had a significant decline in the early 2000s and is slowly starting to increase over the past few years. Back in the mid 1980s, you can see that there is a increase in breast cancer incidence that was really related to an increase in breast cancer screening. And this was associated with both Betty Ford, who was the first lady in the 1970s, and then Nancy Reagan in the 1980s. And it was really the push after Nancy Reagan was diagnosed with breast cancer and the awareness that came with that, and all of the other breast cancer organizations that really, and Awareness Month that came on the heels of that, that led to an increase in screening and increase in incidence. You'll see that there's a drop in breast cancer incidence in the year 2001. And that is really related to the work of Dr. Bernadine Healy, who was the first woman to head the National Institutes of Health. And while she was the head of the National Institutes of Health, she invested in the first clinical trial studying the effects of hormone replacement therapy at the time of menopause. The Women's Health Initiative found that women who took long-term hormone replacement therapy had an increased risk for breast cancer. And so that study was published in the early 2000s, and over those next few years, our breast cancer incidence dropped 2% per year as women came off of hormone replacement therapy. The use of hormone replacement therapy in the short term for symptom management is acceptable, but not for the long term. So we've had recent change in our breast cancer screening guidelines from the U.S. Public Health Task Force. The draft proposal was sent around in May and has recently been adopted. And the primary change in our screening guidelines have been to include women in their 40s for routine screening. The guidelines more than 10 years ago were changed to recommend screening starting at the age of 50. The reasons for the change in the first age for screening was that there has been better science and more epidemiologic studies that have really mapped the incidence and outcomes for breast cancer for women who are diagnosed in their 40s. And what we know is that women who are diagnosed with breast cancer in their 40s are overrepresented by African American women, Hispanic women, and Asian women. So for the year 2023, of the over 300,000 cases of new invasive and in situ breast cancer, there will be about 44,000 deaths. And we know that we can reduce breast cancer mortality with routine screening. For women in their 40s who are screened regularly, these women have improved breast cancer disease-free survival and overall survival compared to women in their 40s who are not screened. And we know this adversely affects Black, Asian, and Hispanic women. This is a very busy graph, but the bottom line when you look at this is that white women represent these black squares where you can see that the incidence of breast cancer is not really until after menopause, after age 50. But if you look at the orange triangles, this represents Black women, where we see the incidence of breast cancer starts at a younger age, peaks earlier, and then drops off. Especially for Hispanic women, we see breast cancer incidence starts much earlier, again, peaks, and then drops off more quickly after menopause. So by increasing the recommendation for screening at a younger age, we know that we're providing a benefit to both Black, Hispanic, and Asian women. Similarly, breast cancer mortality follows this same age-related curves across races. So we have new screening guidelines, and these new screening guidelines really are a change from prior because we are now recommending screening based upon risk and not just age. But all screening guidelines are concordant that we should begin for average risk women screening at age 40. moving from a paradigm of age-based screening to risk-based screening. So what are risk factors for breast cancer? Anyone who had childhood therapeutic radiation would be at the highest risk group. Women with dense breasts, women with a biopsy that shows atypia, women who've had menopause at an older age, who are either have not had children or had children at an older age. These are all breast cancer risk factors. We know that there are primary prevention activities that we do that increase our risk for breast cancer and that can reduce our risk for breast cancer. Physical activity, regular exercise, breastfeeding, and a plant-based diet, we know are protective factors. Factors that increase our risk are postmenopausal obesity, using estrogen progesterone supplements, specifically at menopause, late pregnancy, and alcohol use are other risk factors that are preventable. Breast density is becoming more and more recognized as a breast cancer risk factor. You'll notice that there are breast density reports on screening mammograms now. We know the densest breast can be associated with an up to a 4-fold increased risk for breast cancer. Breast density studies that now that breast density is being regularly categorized and with the use of AI is more routinely managed, we think that the risk might be a little bit less than 4-fold because we have better data to stratify that. Atypia or abnormal biopsy can increase your risk of breast cancer by up to 4 to 5-fold, depending on how much or how many foci of atypia are seen in a biopsy. And any biopsy that shows abnormal lobular features can also be associated with an increased breast cancer risk. Genetics can be associated with a breast cancer risk, and anyone with a family history of cancer can review that with their physician and can consider genetic counseling and testing. We know that genetic testing now is much more affordable and available because of innovations in technology that have decreased the cost. When next generation parallel sequencing became available, we've been able now to offer testing to patients that include multiple genes. It used to be thousands of dollars to test only one gene, and now it's less than $250 out of pocket to test several genes. We know that breast cancer risk can be associated with some high risk, rare variants like BRCA1. We'll talk about that in a little bit. But there can be other lower risk or moderate risk variants that might impact your overall breast cancer risk. And so the risk factors associated for breast cancer include the targets for primary prevention like obesity, smoking, alcohol use, diet, and combined estrogen progesterone therapy. And there are other risk factors that we can't control, like genetics, our family history, atypia or LCIS on a biopsy, and breast density. And those are targets for secondary prevention strategies. So how do we assess breast cancer risk? Well, we know how to do genetic testing to identify gene mutation carriers. And we know how to take a history to identify patients or women who might not be at increased risk. But what about if you have some of these risk factors? We use statistical models to do this. And if you come to the breast center for a breast cancer risk assessment, we're going to use the Tyrer-Cuzick model, which is the kind of the best understood model for breast cancer risk assessment. And it will give us both a lifetime risk of assessment of breast cancer risk as well as a 10-year risk. This is a really busy slide, but it's super important and a point that I wanted to really emphasize tonight. When we do a breast cancer risk assessment and using these models, we're really assessing risk for estrogen receptor positive breast cancers, the most common type of breast cancer and the most easily cured type of breast cancer. Triple negative breast cancers are typically not assessed in those models. And triple negative breast cancer is much more common in Black women as compared to other racial groups. As as you look at the results of this study, I would draw your attention to the far right side where it says HR negative and HER2 negative. These are the higher risk triple negative breast cancers. And you can see these are twice as common in Black women, the orange bar, as in white women, the blue bar. We need to develop better models to identify this risk, the risk for triple negative breast cancer, so we can do a better job screening and preventing these cancers. This was recognized by the National Cancer Institute, who put together a large collaborative project looking for risk assessment for cancer in Black women. What's interesting is this large study identified many of the same factors that we've talked about in terms of breast cancer risk in white women, including the age at first menstrual cycle, age at first birth, but it also includes a family history of prostate cancer, which also seems to be more predictive of risk for triple negative breast cancer. And so if you're Black and you come to the breast center for a risk assessment, we will do this risk assessment model as well. So moving on, our risk models are helpful for the assessment of patients with family history who have African American heritage or Ashkenazi heritage or dense breasts. Our risk models are primarily geared towards estrogen receptor positive cancers. And we will be developing, hopefully before the end of my career, we will have better risk models for the assessment for risk for triple negative breast cancers. So if we do this risk model and we decide you're at increased risk for breast cancer, we will likely recommend screening with both mammogram and breast MRI. MRI has demonstrated improved screening for high-risk women, and our primary findings on screening MRI are going to be within the first 3 years of screening. And then the curves, as you can see, start to approximate each other where the benefit of MRI is not as significant. So in summary, every person should have a breast cancer risk assessment at the age of 25. We should start screening at age 40 for average risk women, or at a younger age for women who are at increased risk. That age could be as young as 25 if you have a gene mutation, or 10 years younger than the youngest age of cancer diagnosis in the family. So what are risk reducing strategies? So, and this is Dr. Fenn's area of expertise, but we have medications that are very effective for breast cancer risk reduction. These medications are targeted to women at increased risk for estrogen receptor positive cancers. And these clinical trials show risk reduction up to 65% efficacy. Again, one of these trials, the IBIS trial, that looked at a class of drugs called the aromatase inhibitors for risk reduction, identified risk reduction primarily for women with estrogen receptor positive cancers. And you can see the difference between the top line, which is women who had a placebo, that was their rate of breast cancer. And then the rate of cancer in the women that had the anastrozole, which is the green line. But we know that the difference between those dotted lines would be the estrogen receptor negative cancers that are happening in this group. And so, again, predicting those cancers and finding methods for prevention there is kind of the horizon. There are 3 classes of drugs that we use for risk reduction. Tamoxifen is the most common one that you might know about. And what's very exciting is a new clinical trial of low-dose tamoxifen for risk reduction. This is a 5 milligram dose compared to a 20 milligram dose, and this dose seems to be very well tolerated by patients. It has the same risk reduction that the higher dose does. with less of the side effects and adverse effects that we could see with tamoxifen. And so we have found that many women, after the publication of that trial, have moved to the 5 milligram dose of tamoxifen and are tolerating it well. And so this has been a real success for secondary prevention for breast cancer. And so we have multiple clinical trials that demonstrate the value of medications for risk reduction for breast cancer. Um, these risk-reducing medications have had some symptoms and side effects that have made them not as effective and tolerable for patients, but we now have low-dose tamoxifen, which has been very effective and very well tolerated by patients for risk reduction. And we'll just talk briefly about risk-reducing surgery. Risk-reducing surgery is really only for women at the highest risk for breast cancer, and women who have high-risk gene mutations or have had previous radiation therapy. And this is an example of a nipple-sparing mastectomy. So this is a case that Dr. Addagatla and I do pretty regularly together. The example here, I think, is a really nice picture because it shows exactly where we place our incision, how we preserve all of the skin and the nipple, and then how the implant is placed on top of the muscle, which is better tolerated by women, and these heal very well. Oh, I'm sorry. Moved into the wrong set of slides there. So I'm going to stop my share and turn the presentation over to Dr. Fenn. Are there any, are there any questions? No.
Great. Thank you so much, Dr. Lynch. That was fantastic. I am going to see if I can share my screen. Give me one moment. Hopefully you all can see. Very good. So I wanted to kind of transition to a medical oncology moment and discuss advances in systemic therapy in treating early breast cancer with a specific focus on immunotherapy. I thought it would be helpful to start and just do some basic talk about what we do in medical oncology. You know, as a medical oncologist, I work in a team with surgeons and radiation oncologists and see patients and offer treatment that treats the whole body. So medications like pills or infusions that are used to treat breast cancer or reduce the risk of it coming back. So when we talk about localized breast cancer, meaning breast cancer that is confined to the breast and lymph nodes, when we offer systemic therapy, we use this to reduce the risk of cancer coming back anywhere in the body in the future by eliminating or preventing the growth of cancer cells in the body. So we call therapy like chemotherapy or medications that we give after surgery, we say that's adjuvant therapy, that's our medical term. And when we give treatment before surgery, we call that neoadjuvant therapy. Both modes of treatment are, with the purpose to reduce the risk of cancer coming back. Though in certain circumstances, we'll offer treatment before surgery, this neoadjuvant therapy, which has additional benefits in certain circumstances to both assess the tumor response to treatment to learn how the cancer is behaving and predict benefit from treatment in the future. And then in sometimes decreasing tumor size or lymph node burden to allow for a successful or smaller surgery. Now we need to understand many pieces of information about a certain case to make a rational and detailed and personalized treatment plan. So one of the most important things, as Dr. Lynch had mentioned, about understanding each breast cancer is the receptor profile or subtype. So there are three things we will always assess for when we diagnose breast cancer. The first two are the hormone receptors, the estrogen and progesterone receptors. When these are present, and they are expressed in about at least up to 80% of cases of breast cancer, it indicates that the tumor cells are using hormones and estrogen as fuel for growth. And the third thing that we assess for is a protein called HER2, which when this is overexpressed in the tumor, indicates the tumor is using this mechanism, the HER2 protein, to grow and divide. These features will predict what treatments people will benefit from. We also, of course, need to understand the stage, which is defined by the size of the tumor, the status of the lymph nodes in the underarm, and any evidence of cancer elsewhere in the body. And then when we see each person, we think about other health conditions, other medications they might be on, and we always take into account people's preferences and, beliefs and desires in order to make a treatment plan that makes sense for each person. And in that setting, our multidisciplinary care is really important. We'll present cases at our weekly tumor board. Where everyone is present, from breast surgeons, radiation oncologists, plastic surgeons, our pathologists and radiologists will review all the data, the pathology, the imaging, and work together, discuss each case to make sure that each treatment plan makes sense, is the right choice from the perspective of all the clinicians involved, as well as the patient, of course. And I want to emphasize, in the modern era, we have many different classes of treatment for breast cancer. And while I'll be focusing on immunotherapy today, we really have seen benefits and advances across the board for all tumor subtypes. Most people know about chemotherapy, which is one of our more blunt instruments to usually IV therapy that kills off rapidly dividing cells. And then we will commonly use hormone therapy or endocrine therapy, so-called anti-estrogen therapy, for hormone receptor expressing breast cancers like aromatase inhibitors or tamoxifen. Monoclonal antibodies are in use for cancers like HER2 positive breast cancer with trastuzumab or Herceptin. And then antibody drug conjugates, which are like targeted chemotherapy drug delivery systems with TDM1, for example, in use for HER2 positive breast cancer. And then finally, in the past few years, we've really seen for early stage breast cancer advances in targeted therapy. So these are often medications, pills that really block or target certain proteins that drive the growth of tumors, including CDK4/6 inhibitors like abemaciclib or ribociclib for hormone receptor positive cancers, or PARP inhibitors for patients who have a BRCA1 or 2 mutation. Finally, immunotherapy is an area of great interest across the board in cancer treatment. And we'll be talking about the role of immune checkpoint inhibitors in treatment of breast cancer, specifically pembrolizumab, which is the one therapy currently approved. So immunotherapy has really revolutionized the treatment of many cancers. We know, everyone has an immune system which defends the body against threats like bacteria, infection, including white blood cells that search for, surveil, and attack microorganisms or abnormal cells in the body, can often even clear out cancer cells at an early stage. But unfortunately, cancer cells can develop methods to evade the immune system. So when we say immunotherapy, it's a broad term that refers to strategies that we can use to harness our immune system, the human immune system, to recognize, destroy cancer cells. That is the goal. And really, as you see on the right, this has been the breakthrough in oncology, or one of the major ones over the past 10 years, and work, of course, is ongoing. The main class of medications that have shown the most benefit in many solid tumors and now in breast cancer in some circumstances are immune checkpoint inhibitors. So immune checkpoints are a system the body has to prevent an immune response that is so strong that it damages normal cells. So cells will express immune checkpoints like PD-L1, which will engage with receptors like PD-1 on T cells, so immune cells, which otherwise might, go on the attack. And when this is present, that interaction sends an off signal, which turns the T cell immune response off. Immune checkpoint inhibitors will block this signal between, for example, PD-L1 and PD-1. And when this off signal is blocked, it allows the T cell, the immune system, to go ahead, move forward, and attack tumor cells when this therapy is effective. And that's the rationale behind immune checkpoint inhibition. Now, in breast cancer, taking a step back, these therapies were developed and showed great promise and response in melanoma, first melanoma, then lung cancer, then others. Breast cancer has historically lagged a little bit behind in understanding how these drugs might be beneficial. Many breast cancers are considered to be, we say, immunologically cold, which means that they're just less likely to respond to currently available immunotherapies. Many cancers do not have many tumor cells involved in the area immune cells involved in the area of the tumor. But triple negative breast cancer, so cancer that does not express the hormone receptors or HER2, this subset of breast cancer is associated with higher levels of that PD-L1 expression and higher average concentration of immune cells in the tumor. Thus is a particular area where immunotherapy was thought to be more effective or potentially had more promise. Triple negative breast cancer is a more aggressive subtype of breast cancer and historically had fewer options for treatment. So this is an area where we needed and still need many more active therapies. So pembrolizumab, which is an immune checkpoint inhibitor, brand name is Keytruda, which blocks PD-L1, was first shown to have benefit in metastatic triple negative breast cancer that has spread to other organs in the body. One phase 3 study showed that when combined with chemotherapy in this setting, pembrolizumab improved overall survival in a subset of patients whose tumors expressed sufficient levels of PD-L1. So this was first approved in the metastatic setting in combination with chemotherapy, and again, really showed promise there, leading to its development and investigation in earlier stages of triple negative breast cancer. The Keynote 522 study was the landmark study that really proved that pembrolizumab was effective in earlier stages of triple negative breast cancer. Busy slide, but this study basically, we know that standard would be to give chemotherapy before surgery for triple negative breast cancer, stage 2 or higher. In this study, patients were randomized 2-to-1, so 2/3 of patients got Keytruda, pembrolizumab, along with chemotherapy, and then 1/3 got just chemotherapy alone before surgery. These patients went to surgery. The response to treatment was assessed, whether patients had any active cancer cells left over or if all cancer cells looked to be eliminated. And then all either received 9 cycles of pembrolizumab or placebo, nothing after surgery, with the goal of assessing, did this improve responses to chemotherapy and did it improve outcomes long-term? And so the answer was yes, adding immunotherapy to chemotherapy before surgery does improve outcomes. So initially we saw that it increased the rate of a complete response to chemo and increased event-free survival, so reduced the risk of cancer coming back or death from any cause in patients with early triple negative breast cancer. And for this reason, it was approved in 2021 for patients with stage 2 to 3 breast cancer, which would be people who have tumor sizes that are 2 centimeters or larger or a positive lymph node. This is a really very big advance. And fortunately, we have even longer term follow-up. And in the past month or so, reported at a meeting and published in the New England Journal of Medicine was the about on average 6 years follow-up from this study. This demonstrated that not only did pembrolizumab improve response rates and decrease risk of cancer coming back, but it actually improved survival. So patients who got pembrolizumab in this study had about a 34% decrease in risk of dying of their breast cancer. Again, proving that this medication is really helping patients long term. We need to understand a little bit more about how much treatment to give, who really needs treatment, and those are questions that are ongoing. So that's why I say, what's the role of adjuvant immunotherapy or the immunotherapy that comes after surgery? We know that some studies have shown that immunotherapy is more effective when it's given with chemotherapy before surgery when the tumor is in place. And studies that have looked at just immunotherapy after surgery have not been as promising. So that's a question if we can tease out who needs immunotherapy and how much do we need to give after surgery. Those are questions that are ongoing. Can we get away with stopping immunotherapy if we see a complete response at the time of surgery? Those are questions that are underway in clinical trials, including one that we have open at Yale. I had mentioned before that triple negative breast cancer is the subtype of breast cancer where immunotherapy has shown the most promise. But we had two really encouraging studies reported out in the past year for a subset of ER positive breast cancer, estrogen receptor positive breast cancer. So these studies noted that patients with this type of breast cancer that have higher risk features, so that are high grade or look more aggressive under the microscope, may also be more sensitive to immunotherapy. And so over the past year, there was a report for 2 phase 3 studies that added an immune checkpoint inhibitor to preoperative chemotherapy in these types of patients with grade 3, stage 2 to 3, hormone receptor positive, HER2 negative breast cancer. And great news was that both these studies showed an improvement in the pathologic complete response rate, which is the percentage of patients who had no active tumor left over at the time of their surgery. The first study used a PD-1 inhibitor called nivolumab with chemo, and then the second study used pembrolizumab, the same drug we were using in triple negative breast cancer with chemo, but both showed similar results. Now, this is not currently FDA approved. We don't yet know if these early improvements in response rates will translate to higher cure rates long term. So it's really what we want to see in order to prove that these therapies are beneficial. So only on clinical trials would we be offering these types of therapies for patients with hormone receptor positive breast cancer. But these trials are ongoing, including, again, one we have open at Yale, where we're using a test called MammaPrint to tease out some of these higher risk patients to enroll in a study where patients might receive an immunotherapy called durvalumab or placebo, again, looking at response rates. Now, I mentioned, we want to tease out who really will benefit from these therapies, and we want to give them to the people who will have the most benefit and avoid if we don't need to give them, because these drugs can have side effects. So we're activating the immune system and with the goal of treating tumors, but these medications can cause activation of the immune system in other parts of the body, or I say, any itis you can think of, these medications can cause it. Now, these medications don't cause day-to-day side effects typically, but in about somewhere like 30% of patients, we might see some long-term effects on treatment, and in about 5%, these effects can be severe. Most common side effects are what we call endocrinopathies. So inflammation in the thyroid, which might require thyroid replacement. We can see effect on the adrenal or pituitary glands. And then we watch out for a slew of other symptoms like diarrhea, which might indicate inflammation in the colon, cough, which might indicate inflammation in the lung. Really, any symptom that someone might have on immunotherapy, we want to know about it, because these side effects, when significant enough, can often be treated very successfully with steroids, but really needs to be addressed. So adding immunotherapy does require some increased vigilance and care. So that's, where we're at with immunotherapy with the current standard in breast cancer. But of course, clinical trials are so important to both assess the safety and efficacy of new therapies. And I included here just some trends in immunotherapy clinical trials. So we've seen, if you should see the lines go up, a real significant increase in the number of open trials enrolling breast cancer patients with immunotherapy approaches, specifically with immune checkpoint inhibitors, this red line. But interest in other strategies like vaccines or cell therapy. And then we see here that while many of these studies have really looked at stage 4 cancer patients, we're seeing more opportunities for earlier stage patients to enroll. And we're seeing more phase 2 and phase 3 studies, so indicating that some therapies are further along in the pipeline and have shown safety and promise. So that's great news. Other strategies that are under investigation but not ready for prime time. Adding an immune checkpoint inhibitor to some of our other medications like antibody drug conjugates is a promising approach, though not yet approved. Adding radiation to immune checkpoint inhibitors also is very interesting. And then other strategies you may have heard of, like CAR T, cancer vaccines, are under study in breast cancer, but really, again, not yet ready for prime time. So only in the circumstance of a clinical trial, and would really encourage any patient to talk with their oncologist about whether a clinical trial is right for them. That's how we offer access to new therapies and learn what the best approach is for management of these sometimes difficult to treat diseases. In summary, so for all types of breast cancer across all stages over the past years, we have really seen a significant improvement in cure rates and survival due to introduction of novel therapies. Specifically with triple negative breast cancer, adding pembrolizumab to chemotherapy pre-surgery has been shown to improve overall survival. But still, most patients who have breast cancer will not have immunotherapy as part of their treatment course. It's not currently approved for use in other types of breast cancer, but as I mentioned, in other subsets or with other strategies, we might be seeing more uptake or more promise. And clinical research, as I mentioned, is the most important way to understand the best approach moving forward and right-sized treatment. So we're giving the best but safest options to our patients for the best possible outcomes. So that is all I had, and happy to take any questions if they're out there. If not, I'll turn it over to Dr. Du. Dr. Du, I think you're muted.
Thank you. All right. Never gets old. As I was saying to my muted microphone, that my name is Kevin Du, as we were talking about earlier, and I'm associate professor here in radiation oncology at the Yale School of Medicine, and also I have the real pleasure of being medical director here at the Trumbull Radiation Oncology Center and taking care of patients here at this amazing cancer center. And I'm really gratified to see on the attendee list so many of patients that we've taken care of together, and thank you for joining tonight. So I'll be talking about radiation therapy in particular. I think one thing which has been a very, hot topic in recent years is really the idea of personalizing patient care and de-escalation of treatments, and which patients can we think about in terms of trying to improve their quality of life by reducing treatment or avoiding treatment. And so I just thought I would start with this picture because I was walking to my office this morning, and this is our beautiful Norma Frame healing garden in full fall colors, amazingly beautiful day. And it's kind of a daily reminder of where I think it's really a real it really just shows the amazing support that our cancer center has from our community, that we can have things like this in our cancer center. And of course, I'm really very grateful for the support that we have from cancer, and I'm very grateful for the patients who are online and who we get to treat, who choose to get their treatment with us. And it's an amazing place to take care of patients. And really, I thank all of you for deciding to come here to us for your care. It allows me to do something which I really think is a rare opportunity, which is to help people when they need help. And so thank you. So this is Breast Cancer Awareness Month, and this is the topic. So the road ahead in my talk, we'll start off by talking about a very quick thing about what is radiation. Again, many of you I'm seeing have actually had radiation, but some folks may not be as familiar with what radiation is all about. And then I'll talk about small favorable biology breast cancers where we really think about, do patients need the kitchen sink, or are there things that we can not treat with? And then, an emerging question for node-positive breast cancers, which are, a little bit more biologically aggressive, whether or not we can avoid treatment in that patient population. And then going through really some of the side effects of radiation and what we try to do to, again, personalize care and try to reduce the side effects of radiation. So first of all, what is radiation? It's kind of interesting. I have maybe too much education, and so I kind of think of radiation as something that we've kind of grown up with. Our planet Earth is bathed constantly with cosmic radiation, and our evolution actually has evolved with radiation, and so uh, there's a lot of um, things to think about in terms of how our biology reacts to radiation and how we can take advantage of that, really to with advances in our understanding in the past century of physics, nuclear physics, molecular biology, and technology that we've had really huge advances in. And all this can be combined, if we think about it in an intelligent way, to really try to maximize what we call the therapeutic window of radiation. That is trying to maximize the tumor control, the cancer control, and trying to minimize the side effects of radiation. And really the themes that I think about when I think about radiation are themes over the history of how we use radiation for cancer care in terms of organ preservation, helping patients with how they function after cancer treatments, and then also the possibility of how can we improve our response rates to radiation and cure more patients. And this is a picture of one of our linear accelerators. This is one of our radiation machines and our amazing therapists here that help our patients to deliver the radiation treatments. And this is basically a big X-ray machine that aims radiation at the patient. And what happens is, the radiation gets emitted, X-rays from the head of the machine while the patient lays on the treatment machine. And as this is shown here, we are able to focus the radiation on the breast of this breast cancer patient. And we're able to shape and modulate the radiation field with these lead leads that are in the head of the machine. And it's a team effort, as everyone has been saying here tonight, and I get the amazing privilege of working together with all these amazingly intelligent, dedicated, caring physicians, all working together to take care of our patients. So in small favorable breast cancers, I would say that across the board, and this is actually, by the way, not just for breast cancer, but across the board in cancer care, we're thinking about how can we de-intensify treatments for patients where we're very successful in curing patients, and thinking about again, does everyone need the kitchen sink, or how can we improve patients' quality of life by really kind of being more measured in how we're treating patients? So in surgery, this is being thought of as, can we do smaller surgery or no surgery? Can we reduce surgery? In radiation, we're thinking about, can we omit surgery for some patients? Can we give less radiation or smaller areas of radiation? For chemotherapy, it's already routine where we used to give chemotherapy to everybody, to use molecular testing, the Oncotype tests to avoid chemotherapy in most patients with early stage breast cancer these days. And that's been a huge advance in the last 20 years. And then as Kathleen, Kathleen Fenn's expertise, chemotherapy, endocrine therapy, are there things where we can give less endocrine therapy or in some cases avoid endocrine therapy? So in some ways, this is actually a central theme of early stage breast cancer history, which is it used to be 50 years ago that every patient would have a mastectomy, as you can see here, and this is just a big surgery for early stage breast cancer. And these days, as Dr. Lynch will talk to most of her patients with early stage breast cancer, that most patients don't need a mastectomy, and a lot of patients can actually have a breast conservation surgery, just remove the tumor, and then use a combination approach where you combine this smaller surgery with radiation to clean up after these smaller surgeries and avoid a mastectomy. And this is a classic example going back to the 80s, right, of an organ preservation approach and doing less surgery and improving patients' quality of life, right? So this is this is something where we're talking about already 40, 50 years ago, de-intensifying surgery and a real success story for breast cancer treatment. And so this idea of de-intensifying treatment is not new, right? And it's something that I think is very valuable for patients. So these days, 50 years later, now we're asking, well, we've kind of de-intensified surgery, but our outcomes are so good with this breast conservation approach. Can we actually de-intensify other things? Can we avoid radiation, for example? And in recent years, for favorable biology, very small early stage breast cancers, and this just happens to be a quirk of how we're doing the clinical trials for older patients, that maybe we can avoid radiation treatment. And there have been two studies in the past few years that have had a lot of traction and a lot of press. And the take-home point, and there's a lot of graphs and numbers and things, and I apologize, I'm not going to go through all of it. But as it turns out, for these patients, if you do a breast conservation surgery, a lumpectomy, or a partial mastectomy, and you randomize patients to radiation or no radiation, as it turns out in these patients, there's actually still about a benefit in terms of local regrowth of cancers within the breast of about 10%. And radiation then adds to the local control and reduces the risk of breast cancer recurrence to about 1 to 2%. So I would say that's a small enough benefit that these days I'm routinely talking to patients who fit into this very favorable subgroup about asking patients, is that 9 to 8% benefit worth it for you to do the radiation? And that's a very patient-specific choice, and it's very much up to the patient how they feel about that, not insignificant, but not huge benefit, right? And again, this is for very favorable patients. And so some patients would tell me, yes, I think that's fine. I'll leave that benefit on the table, and I'm very comfortable with that. Other patients would say, look, I really want every benefit, and they'll, want to go ahead with the radiation. But this is an option for patients, and it's something that we talk about a lot these days as a reasonable option to avoid radiation if you're willing to accept a little bit increased risk of recurrence within the breast. And by the way, this is not everybody with early stage breast cancer. So, there's some biological features where the rate of regrowth actually increases substantially. And for these patients, interestingly enough, because this is a team effort and this is a package treatment of surgery, radiation, and then importantly, endocrine therapy after radiation. For patients who didn't complete endocrine therapy, they actually had a big jump in terms of the risk of local recurrence. And so it is important, and I tell patients that if they are worried about the side effects of endocrine therapy or worried they won't be able to tolerate endocrine therapy, they absolutely should talk with Dr. Fenn to try to get a better idea of tolerance and things that the medical oncologist like Dr. Fenn can do to make endocrine therapy more tolerable, because that's actually a very important thing if you're going to omit radiation. Um, and so, sorry, I apologize, flipping back and forth. So again, this is something where radiation does have a benefit, but what happens if we look at even more favorable patients? And Dr. Fenn was talking about the value of clinical trials, so I'll just throw a plug into this clinical trial that we have here open at Yale, which folks can ask about, which is omission of radiation in favorable early stage patients, but then also adding in this kind of molecular test. I mentioned it earlier, the Oncotype test, which we use primarily for chemotherapy decisions now. But if the risk of recurrence is low enough by Oncotype test, patients can actually think about enrolling on this trial, which again is trying to find a favorable subgroup of early stage, favorable biology breast cancer patients who may be able to avoid radiation and not impact their risk of recurrence. And this trial then is looking specifically at the question of, for this even more favorable group of patients, assigning them to either radiation or no radiation. And this is a really nice trial, which is getting an important question again to see if we can avoid radiation. And again, I'll emphasize all patients on this trial must really take endocrine therapy. So the question then is, as I've been talking about these trials and the results and the importance of endocrine therapy, is that, what happens if a patient, takes radiation or takes endocrine therapy? Do they need both? Or can we omit one or the other? And these are three trials that were done. They're kind of a little older now. So, this is about maybe 10 to 20 years ago at this point. But there's ongoing trials looking at this as well. But just to kind of give you an idea, and I think maybe, this is kind of an interesting thing for local recurrence from this series. It was actually very low. This is actually incredibly favorable low-grade patients, and the local recurrence with no treatment is actually 2%, which is incredible. I mean, this is like a very favorable subset of patients. Either radiation or endocrine therapy alone, either one, reduced that further to 1% each. And then together, if you gave both, it was basically virtually 100% of these patients that were cured. This is not every early stage breast cancer, though, and I think these other two trials are maybe more reflective of what we think about in terms of typically what we see. And in this trial, looking at observation, nothing, versus endocrine therapy, radiation, or both. If patients did nothing, the risk of recurrence, regrowth was about 30%, pretty high. But for radiation, that reduced it to 13%. For endocrine therapy, that reduced it to 10%, about the same, whether you did endocrine therapy or radiation. And then for both, it reduced it a little bit more, down to about 7%. So, if you do both, you probably have a little more benefit, but one or the other is actually pretty good in this trial. And then this NSCBB 21, very similarly to this German trial, is if you took endocrine therapy alone, it reduced your risk to about 17%. And then if you did radiation, that reduced your risk to about 9%. And if you did both together, it reduced your risk to about 3% of recurrence. So this is something where, these are all very favorable numbers, but it just goes to show that we're so good at curing early stage breast cancers that we're really getting, if you do everything, to the high 90% range. And even if you're not going to do one or the other, we're still probably still in the maybe low 90% range, upper 80% range. And that's something that is really optimistic. And again, why we're even talking about the idea of trying to de-escalate treatment. And then, sometimes it's easier to look at curves, but this is just a population-based study from Canada and really reflecting that probably what I talk about with my patients with early stage breast cancer, which is, probably if you don't do anything, but you have excellent surgery like you will with Dr. Lynch, probably the risk of recurrence is somewhere in the range of 10%. And then if you do radiation and endocrine therapy alone, you're going to the upper 90% cure. But you should probably do one or the other, if not both. So that's something that is an important take-home point. So ultimately, this is a really important question these days, which is, which treatment would you do, radiation, endocrine therapy, both? It's important to emphasize, as much as I'm going through all this data, that at this point, it really is still the standard to do both. And that's important because we think that small differences, even though they're small, they're very important in breast cancer. And we treat so many breast cancer patients, and unfortunately, breast cancer is just such a huge problem across the world, that these percentages actually scale up, right? So when you're talking about one patient, yeah, we can talk for hours about this, and is it worth it for any one patient? And we do. But if you're talking about, hundreds of thousands of patients, this actually scales up to a really meaningful benefit. And that's where the question comes in. So that being said, next thing to talk about is we're also doing smaller radiation. And a lot of patients come in and talk to me about, can we just treat part of the breast and not treat the whole breast? And this is an example of a partial breast plan where this colors here show where we're focusing the radiation. I would say that this is something we can talk about. It's certainly an option for many patients, but ultimately speaking, from what I can see from the data about it, there's a small difference in reducing risk of recurrence between treating the whole breast and part of the breast. And there's also a small difference in side effects between treating the whole breast and part of the breast. So this is something we should really be thinking about on a case-by-case basis, and absolutely happy to talk to people about it. So moving on then from the case of small favorable breast cancers, and I'll finish up in just a few minutes, is also the idea of node positive breast cancer patients. And sometimes breast cancer can spread to the nodes. I think even if breast cancer spreads to the nodes, just to be somewhat reassuring about this, is we still can think about it as a very favorable situation with appropriate treatment. We have this, we have some, a lot of studies looking at this, and I usually would look at this combined analysis where they're kind of looking at all the studies and combining all the patients together. And this is a great group that does these what are called meta-analyses, where they put together a lot of different trials. And patients with any nodes would have about a 20% chance of recurrence over 10 years, and about improvement with radiation. That is, the benefit of radiation would be about 20% in terms of risk reduction. And then also about a 8% improvement in breast cancer related death over 20 years. And so radiation for breast cancer patients is actually with lymph node spread, is actually very important. And I would not think that patients would really, unfortunately, benefit from reduction of radiation if they have spread to the nodes. And they've even tried to look at kind of limited lymph node spread. And we would actually say that limited lymph node spread is still early stage breast cancer with very favorable outcomes. So 1 to 3 nodes, radiation still had about a 15, 16% 10-year benefit in terms of reducing risk of regrowth in the breast, and about an 8% improvement in 10-year breast cancer related deaths. So unfortunately, I think for patients with lymph nodes, we were talking about this now, but at this point in time, I'm still routinely recommending radiation for patients with lymph node involvement. So just to finish up the conversation with, what do we think about? We've talked about, the benefit of radiation. What about the side effects of radiation? And the first thing is time. A big side effect of radiation, which is that, I'm asking patients sometimes to come in for weeks of radiation treatment. So traditionally, maybe 20 years ago, the most common treatment would be about 6 to 7 weeks of daily radiation. We've actually shortened that now to about 3 to 4 weeks routinely. The one exception is sometimes we treat 5 weeks if we're treating the lymph nodes. And then even for early stage breast cancers, we even have options for even shorter treatments, a 5 treatment regimen. And, these are all kind of, again, very patient specific, what we might recommend. And these are things that certainly I welcome conversation about when we would pick one or the other. But we're trying to make radiation more convenient for patients and, less investment in time. The way that we give radiation, our technology has improved greatly. So these days we're using a lot of computer power and imaging power. This is an example of one of our radiation plans, one of my radiation plans, where we have this color wash of radiation across the breast, and really avoiding very nicely the lung, which is this black area, and the heart, which is this area. And really being very focused on the radiation treatment. And this is actually with our modern radiation techniques, we can actually improve a lot of the side effects like skin peeling. We can improve how things look and feel in terms of cosmetic outcomes after radiation. And these are things that have been shown to be improving over time as our technology gets better. But there are still side effects to think about. The main one, which many of this is where Dr. Addagatla will be talking after I'm done, is really asymmetry, where the where the radiation that I give can cause a lift or a reduction in size of the breast that I treat compared to the other side. And this is probably the most common side effect that we think about with radiation treatment. There are things we can do to try to mitigate that risk. Again, our radiation planning has already reduced the risk of this, but larger breast size, older age, and very importantly, in terms of what patients can do, is smoking has been associated with increased risk of this asymmetry that happens after radiation. And so certainly smoking is something that is a modifiable risk factor and probably better overall in terms of just overall health. Lymphedema is another big one, especially when we're treating the lymph nodes. And I think, the combination of surgery with radiation especially really increases the risk of lymphedema to about 30–40%. What we can do though is we can do 2 things. One is if an axillary dissection, removal of all the lymph nodes to remove the cancer in the lymph nodes is necessary, we can actually avoid that with adequate dissection. A lot of lymph nodes removed, we can actually avoid that region these days with radiation and really treat the maybe next echelon kind of lymph nodes, but not directly where the surgery has already done a good job about clearing things. And that actually can drop the risk of lymphedema down to, this is kind of an optimistic number, but less than 10%. And we actually can think about, this is again, de-escalation and choosing which treatment. We can actually think about if someone has a lymph node involved, maybe they don't need surgery to remove all the lymph nodes, and we can actually clean up the axilla and the lymph nodes there with radiation instead of surgery. And this has been shown to actually help with the risk of lymphedema. Together, if you're doing the lymphedema risk is actually improved when we do radiation instead of a full axillary dissection. And this is an approach that we're doing very routinely these days. And again, a great example of how not every patient needs the kitchen sink, and we can kind of very safely these days with clinical trial results say that we can use radiation instead of axillary surgery. And then cardiovascular risk, I'll finish up, is something that a lot of patients worry about, and we worry about with radiation. The other side effects that I'm talking about are really not life-threatening necessarily. They're things that are very important in terms of how a patient looks and feels, what we call quality of life, which of course is extremely important. I'm not minimizing that. But the heart is medically, very important. That's critical for life. And, it used to be that the risk of heart complications is actually much higher than it is now with modern radiation techniques. And these days, when we're fully acknowledging the risk of heart exposure of radiation, which increases the risk of cardiovascular disease, we know now that the more radiation the heart is exposed to, the higher the risk is of having heart disease because of that. But this study actually was really great in about 10 years ago now, really put a spotlight on this. And since then, we've really paid a lot of attention with our radiation planning to trying to avoid the heart. And in many cases, we can actually these days block off and avoid heart exposure entirely, which is the ideal. Even in patients where we are not quite able to block off all of the heart, for our goals of what we try to limit the heart dose to with radiation, the risk of having an acute coronary event, having a heart attack, for example, is small. And again, for our goals of this is kind of technical. A gray is the unit of radiation we use for the goal of heart exposure, limiting the heart exposure to below 3 or 4 gray. The risk of having a heart attack, for example, would increase by less than 1%. And if you think about in general, a healthy person, low risk of cardiovascular events, about 4 to 5% risk in the general population, this type of radiation exposure would increase their risk to 5.4% from 4.5%. So this, of course, goes up if you do have cardiovascular risks, and this is where heart health is very important for breast cancer survivors. And patients will be followed in our survivorship clinic and talked to about endlessly about the very important things of heart health, exercise, healthy diets. All these things are very important to minimizing that risk. But overall, the cardiovascular risk is very low for breast cancer patients these days because of our radiation treatments, and really very preventable. So that being said, the last thing we worry about in radiation is a second cancer. And, this is kind of one of the things we worry about with any radiation risk. If you get a chest X-ray, a CT scan, any radiation exposure, you really want to make sure that the risk is worth that the reason you're getting one of these scans is worth the risk of the radiation exposure. And we really try to minimize radiation exposure in the general population for what is very intuitive reasons these days. So we have looked at this because we've used radiation for 150 years now for treating cancers. And with modern radiation, they've really looked at this over years, and the number of excess cancers in patients that have been treated with radiation is about 5 cancers per 1,000 patients. And this is cancers that have come up possibly because of radiation treatments. But really only about 8% of these can be directly attributed with confidence to radiation. So you're really talking about something like somewhere between 1 in 1,000 to less than 1 in 100 patients who may have cancers because of the radiation treatment. And I think that's important because we've been talking about numbers, even in favorable breast cancers, of cancer recurrence, which exceed that. So we think about, again, the therapeutic index of radiation, and that, we want to make sure that radiation treatments are worth it and the benefit outweighs the risk. And so while it's counterintuitive to think about, yeah, we're using radiation, something which may cause cancer, to treat cancer, this is something which we think that the risk of a patient's current cancer is higher than the risk of future cancer because of the radiation treatment. And we still think that the radiation is worth it. So ultimately, the risk of second cancer because of radiation treatment is low, and most folks are reassured by this. But again, this is kind of a very patient-specific thing, what kind of risk they want to assume with the radiation treatment. So ultimately, I would say that this is something where hopefully this has been helpful to understand what radiation is, that we are trying in small favorable breast cancers to reduce our use of all of the treatments, and that it's very patient specific. And we have a clinical trial here at Yale that I encourage folks to ask about. And then in node positive breast cancer patients, a little bit higher risk, the benefit of radiation becomes more substantial. And, we are trying to look at, for example, patients who are very chemosensitive. Can we avoid radiation in that group? But I would still say that most folks around the country are still recommending radiation, despite this idea of, again, can we avoid radiation for folks with nodes in the most favorable patients. And then, the side effects, again, are very real, unfortunately. But I would say that many patients we think about as doing well with radiation, even though, I think it's very important that we do pay attention to the side effects. And, I don't by any means minimize any side effects that patients get. And we're here to help you with those side effects if you do have them. But that's this is again where those of you who have been treated with me, this sort of conversation that I've had is very familiar to you, and you've heard this. But this is kind of the pluses and minuses of radiation, and we're here to help you get through it. So I'll just abbreviate this and say that, in breast oncology, we really are, I'll echo what Dr. Fenn said, which is that clinical trials are just so critical, and we really need to improve our treatments. We're working to improve our treatments. And breast cancer over the past, half century has been a real success story in terms of how many more patients we're able to help. And, I think that shows because we're talking so much about how many patients do well with this. So this is something where, again, I'm very grateful to the patients who choose their care with us and who participate in these studies to help us help more patients. So thank you very much, everyone. I'll turn this over to Dr. Addagatla and stop sharing here.
All right. Thanks, Dr. Du. Good evening, everyone. It's a pleasure to sort of round out the talks this evening. And I promise it's going to be lighthearted and fairly brief. So hopefully we'll get to finish close to being on time here. But I think the topic I chose for this evening to speak about is sort of the general reconstructive journey and how an initial consultation would look like if you were to come see me or possibly any other plastic surgeon. What are some of the highlights that you might want to think about? And I think it's important to hear these things as a one-time, at least, to start on a high-level overview, and then things can obviously be dissected into and really discussed in more depth in more specific conversations. I have no disclosures other than to say that Breast Cancer Awareness Month is here and early. So I started with this image to note that we all hear this, that this is a journey, and once you're sort of hit with the diagnosis, it can feel quite daunting, and it can feel like you're alone on a long, winding path, and not knowing which way to go, not knowing what the end result will be. Um, and I think it's for that reason important to make sure that we start by understanding your goals when we first meet. What did your life look like before you were hit with the diagnosis? Do you have any children? What is your occupation? Are you able to take time off from work? What are your hobbies? What are your activities? What do you like to do? And from an emotional standpoint, what is your tolerance for the length of this journey? How short do you want to make it? Of course, everyone wants it to be as short as possible, but are you willing to sort of take a longer road if need be? And what are your ultimate goals of how you want your breast aesthetics to be at the end of the day? It's important, of course, to understand from my perspective what your support system is. A lot of what I do from a reconstruction perspective can be quite challenging if we do not have much support for the patient at home. So that comes into play as to, what kinds of things we might offer as reconstructive options. Um, we'll also take a look at and assess various risks that you might have coming into the reconstructive discussion. And that might be things that you've already discussed with other members of our team, such as have you had or will need, chemotherapy beforehand, before going through surgery? Might you need radiation afterwards? And what are the chances that you might need an axillary lymph node dissection where not just a few nodes, but many more nodes are taken as part of the oncologic or the breast cancer surgery? Smoking status, as Dr. Du had mentioned as well, I think is very important for us to know, especially from a reconstruction perspective. And what other significant medical problems do you have? Have you had any other previous surgeries that might limit us in one way or another? And have you had a history of radiation in the past? When you see us, I'll pull out one of these roly-poly measuring tapes, and I always joke with patients that it's similar to going to the tailor, not quite. But I have to get some measurements on you and figure out kind of what are the dimensions of your breast and how does it project and what is the base width, et cetera. And so we try to get an understanding, objective understanding of the dimensions of what you have and where we need to go and where we want to go. I wrote down ptosis or droop of the breast, and that's comes into play quite often as to what kinds of procedures we might offer because of that. Everyone has a different body type, and certain body types lend themselves better to certain different types of reconstruction. And then others, for example, those who might be on the heavier side, might have a little excess in their lower belly that we could use to our advantage to help reconstruct a breast. And so that will come into play as well when we discuss different options for you. And I promise I won't gross out with too many pictures here, but I wanted to at least put this one up to give you an understanding of what I'm thinking about when I'm consulting with you. And I think what is important for the patient to know going into the reconstructive efforts. This is some pictures of what normal anatomy would look like. And once the mastectomy is done, we're coming across a lot of the blood vessels and nerves that feed the skin and the nipple. Just by nature of the surgery itself, to have to remove this tissue, you're going to come across some things. And so that's going to make the blood supply to the skin a little bit more tenuous. It's going to make you feel numb on the skin itself. And those are things that we talk about and try to understand. And on this picture on the right, it shows that, we're not just removing a disc. Dr. Lynch, when she goes in, she's not just removing a disc, she's going in a certain trajectory and taking out the breast in its anatomic position. And so it's very hard to recreate that is removed with simply a disc or of an implant per se. And so I always say the statement that we cannot completely recreate the natural breast. And I put the caveat here in 2024 because, believe it or not, there are definitely people out there who are trying to recreate breast tissue and the like. And so the goal, there are people out there working towards trying to recreate the breast as its whole, but currently we do not have that. And so what are potential surgical options? We'll go through some, again, high level views on this, just to give you an understanding of what might be, you know, in discussions with you. If from after meeting with your breast surgical oncologist, like Dr. Lynch, if your cancer is amenable to a partial mastectomy as opposed to a complete mastectomy, then when we meet, we might discuss how we can reconstruct your breast to utilize tissue that is either within the breast, if you have a large and maybe even ptotic or droopy breast, with a favorable size of cancer that's not too large, where we can utilize the remaining breast tissue to rearrange it strategically, keeping in mind the specific, blood vessels that supply the breast, and rearrange it in such a way that we can create a nice mound under the skin again and fill in that defect where the cancer was removed. We might even move in tissue to the area, to the breast area from nearby regions as well. And so that all comes under the category of oncoplastic reconstruction. And I think this quote is quite nice to say that oncoplastic breast reductions combine oncologically sound concepts of cancer removal with aesthetically maximized approaches for breast reduction. And so in doing this, you hear you're connecting the word cancer to plastic, and please keep in mind that we're always keeping the oncologic safety of utmost importance first when we consider doing these kind of procedures. Should you have a mastectomy, of course, again, an anatomic picture here, I just want you to understand that the mastectomy is the breast tissue removed. So what's left behind is the skin that's on top and a very thin layer of fat underneath. And then you're left with a big cavity. So what do we do when we have this redundant excess skin and a cavity? How do we reconstruct this? Well, the first option actually would be to discuss a flat closure. Not something that necessarily push on patients, but I want you to at least know that you don't have to have a breast reconstruction, right? Reconstructed. It's not a life-saving thing. However, many women choose to have a reconstruction. Should you choose to not have one, there are many different incision patterns that we can use to try to keep that side or both sides of your breast, of your chest, flat as possible. And some women are choosing to go this route, and that's totally fine. And I want you to know that that is something that we can offer for you, should that be the case. However, many women do choose to have a reconstruction, at least to fill in that pocket that's left after the mastectomy is done. And one of the ways to do that is to use an implant. And an implant can be placed in two ways. The first way would be what we call a direct-to-implant reconstruction, or DTI for short. On the pictorial representation here on the left, you might hear this in both ways being performed, which is why I placed this here. One way is to lift up the pectoralis major muscle, which is sort of one of the chest muscles that you have, partially lift it up and place the implant under that muscle. The other way, which I favor, and I know Dr. Lynch does, and we work together closely as a team to do it this way, is to place the implant above the muscle. We find that it's a lot more comfortable for patients. In order to do this, I do use what's called ADM, or acellular dermal matrix, which is skin that comes from someone else where the cells are removed. So it's simply a matrix into which your body incorporates and grows, and it becomes your own. And that's thought to decrease your risk of what we call capsular contracture, or basically firmness of the breast later on down the road. So it helps to keep the breast soft in its appearance and feel down the road. And that's why we use it. And these are just examples of what implants might look like. The other way to do this is in a staged fashion, where there are times where we feel we may have to use an expander. An expander, you can think of it like a balloon, and it has a port that is similar to the port that one might get for chemotherapy. And we can find this port using a magnet under the skin, and in the office we can carefully inflate it with saline to the size that we want. And we do this for various reasons. One of the reasons might be that again, the blood supply might be compromised to the remaining skin and tissue underneath. And so we might not be ready to put in an implant directly right away. And sometimes that's a decision that we make in the operating room. Even if we go in thinking we're going to place an implant, we might have to resort to this. And that's something I counsel patients on. You might wake up different than plan A. And that's, we just kind of go with the flow in the operating room. And then the other category to which this might be used is if one wants to have a larger end size of their breast than what they currently have. And so the way to do that is to expand the remaining skin and tissue to then accommodate for a larger breast size. And that, of course, is later switched out to a softer implant. And finally, the last way you can try to reconstruct a breast and the breast mound is a much more involved approach, and we call it an autologous reconstruction, also known as a free flap reconstruction. And you can think of it like transplant within your body. We're using your own body tissue to reconstruct a breast mound. You may be able to understand the concept of a liver transplant where one's liver is removed and someone else's liver is brought in to hook up the piping and the connections and allow that body to utilize that liver. In a similar fashion, we're actually removing skin and fat, and that's our organ. And we're carefully dissecting the blood vessels that feed that organ, which are an artery and a vein. We dissect that through your six-pack muscles or your rectus abdominis muscles, all the way down towards your groin, and then bring that up to your chest and connect it to vessels that are in the chest. And so since it's your own body tissue, you're of course not going to reject it. And since it is your own tissue, we can only really use what you have. And so this is where it comes into play to talk about what your body size and shape is, because if we don't have much of what we call a donor site or a place where we can take from, then we may not be able to use this kind of a reconstruction. And so that's one option. If a nipple has to be removed, you should understand that there are several ways to reconstruct it. First of all, we can try not to remove the nipple. And that's on the top left there, and we call that a nipple-sparing mastectomy. And so the plastic surgeon, in conjunction with your breast surgeon, I work very closely with Dr. Lynch. We talk all the time about how we can save these nipples. We work very hard to do so. And of course, this has to be, aesthetically and oncologically sound to do so. But our first attempt is to try to save the nipple without removing it. If that's not possible, we might consider removing the nipple as a skin graft. That's called a free nipple graft, and then suture it back on in the correct position to allow for maintenance of the nipple in that position. But should you have lost a nipple or lose the nipple along the way and not have that, you can definitely consider a 3D tattoo. And these are actually covered by insurance now if it's done by a medical provider. And we have at least one of our physician assistants here, and we have someone out in New Haven as well, that can offer this for you in the office and under some local anesthesia if you need it. It's again covered by insurance, and you get some really impressive results. Visually, a lot of patients feel that their reconstruction is finally complete when they can look in the mirror and see a nipple on their breast mound. If need be, we can also reconstruct nipples sometimes by utilizing some remaining tissue and kind of bringing it up as a projecting mound. I'll just close this out by speaking a little bit about some newer procedures that are out there that you might hear about, and so I'll just briefly mention them. One is neurotization, and what this means is when the breast tissue is removed, we talked about how the blood vessels are inadvertently come across. You have to cut through them in order to get the breast tissue out. In a similar fashion, you have to cut through the nerves, some of the nerves that come from deep down where that chest muscle is towards the skin. You have to come across them to get the breast tissue out. But what some folks are trying to do now is connect some of those cut nerves, or at least one of those cut nerves, to the skin, to the mastectomy skin. I will just mention that this is still very new. The science is very new. The results are still coming in. At best, I've heard of results in the range of 50% chance of this maybe working. However, um, you should know that it exists. You should know that people are doing this out there. And if it's something that you want to consider, you should definitely discuss it with your plastic surgeon. Another thing that has come out in recent years is what we call immediate lymphatic reconstruction. This goes back to a lot of what Dr. Du was saying and Dr. Lynch and everyone we talk about the risk of when you take out these nodes, remove the nodes, or if they get radiated, does that then increase your risk of what we call lymphedema or swelling of your arm? And that swelling, unfortunately, once you've been diagnosed with lymphedema, there's no known cure today to resolve that. And so what we're trying to do now is if we know there's a possibility for you to undergo an axillary lymph node dissection where they remove more than just a few nodes, we can at that time connect your lymphatic system to your veins in order to try to bypass the blockage. And so this is an example of what lymphedema might look like, where your arm is, you can see the patient's left arm is enlarged and different stages of lymphedema as well. And so in order to try to prevent this, what we would do is those highways, those kind of in this pictorial representation, the yellow highways, or there are some green highways that go in from your arm towards your armpit and axilla and then ultimately back towards your heart, they go through, those highways go through and they stop at filtration systems. And those are the lymph nodes that are removed during the axillary lymph node dissection. So in essence, you're cutting and you're putting a roadblock on those highways. We take those highways in this right pictorial representation, those green highways here, we take those and then connect them into a vein that then ultimately goes back towards your heart. And if you're ever curious, you should bring out a ruler or measuring tape and look at the measurements on it. These lymphatic vessels are about 1 millimeter or less in size, and so they're really tiny. And so, frankly, I always tell patients that whether I do this to you or not, you may not know. It's not something you can feel. It does add more time to the procedure, but it's what we're trying now these days to see if we can try to improve your or prevent your chance of developing lymphedema, because we know that we don't have a cure for. And studies so far are very promising on this, and so we're trying it, we're doing it, and if this is something that might be in your future, such as getting an axillary lymph node dissection, I think it's worth speaking to your surgeon about whether they can offer this for you or not. And so with everything in your decisions, there are risks and benefits, and we just always have to weigh one to the next. In summary, this is a long road. It's a long journey. You can feel like you're feeling alone. And it can also be quite confusing at times because with all the information that was presented to you today, with everything that I would speak to you about for reconstructive options, it's very difficult to know which path to take. And so I think it's all that more important for you to have that support system to help guide you and also have a very strong team, medical team to help you with these decisions. Put the onus on us a little bit. We should hear everything we have to say as a fire hose, but you can also ask us how we would, guide you. And we might help narrow those options down to just a few to help you decide a little bit better. But ultimately, your team you should feel comfortable with, you should have a good relationship with, and you should feel like they're on your side and giving you the time that you deserve to navigate this challenging time. And so with that, I'll say thank you. Happy to see any one of you and any of your friends, anyone that you want to have any kind of reconstructive consultation with. My office is here at Park Avenue, and happy to see anyone. I'll take any questions. Thank you so much.
This was an awesome group tonight. I'm so glad to get to be part of this with all of my valued colleagues and all of our wonderful patients. Dr. Du, thank you for welcoming all of our patients to this evening. It was really great to see all the very familiar faces. It's a joy to come to work here every day. It's really our colleagues and our patients that make all the difference. Any questions that come in over time, we'll certainly be happy to answer. And, we're really grateful for this location here at Park Avenue too. I'm looking at in the chat this is a lovely place to work and also to provide care. Right, I think was moved to go till 7:30. Okay, well, if there aren't any more questions, then we'll say goodnight to everybody.
Thanks so much. It's a pleasure.
Thanks, everyone.
Have a great night. Thank you.